In this lecture, we're going to look at the pancreas, the liver, and the gallbladder. So we've just finished a series of lectures looking at the organs of the GI tract, or the digestive system. And here, we're finishing the digestive system by looking at the accessory organs, those organs that are not part of the GI tract, but secrete into and provide necessary functions for the GI tract. We will look at the pancreas, the liver. Specifically through the liver, we will also look at the hepatic portal circulation and look at the flow of bile starting from the liver and ending in the small intestine, and how the gallbladder functions to store that bile and help to secrete it. So the pancreas, liver, and gallbladder are accessory organs to the digestive tract. They are not part of the digestive tract, but they have a very important role to play in digestion. They also have other non-digestive functions. Both the pancreas and the liver produce important secretions that will enter the duodenum of the small intestine. The pancreas produces enzymes and bicarbonate. The liver produces bile. The gallbladder doesn't produce bile, but serves as a storage site for bile. Here's a list of the pancreatic and liver secretions. These are all the enzymes from the pancreas, but also the bicarbonate and aqueous solutions, and then from the liver, the bile. Let's start with the pancreas. The pancreas lies behind the stomach. It's retroperitoneal, and it's tucked into that C-shaped structure of the small intestine, the duodenum. It has important exocrine function, meaning it produces enzymes that are delivered to the lumen of the digestive tract, digestive enzymes and bicarbonate. That bicarbonate neutralizes the acidic chyme entering the small intestine from the stomach. And these secretions are going to travel through the pancreatic ducts. There's a main pancreatic duct and an accessory pancreatic duct. These will enter into the duodenum. The main pancreatic duct joins with the bile ducts at a structure called the Hepatopancreatic ampulla. Hepato for liver, pancreatic for pancreas, and ampulla, that region where they meet up. The secretions from the pancreas are referred to as pancreatic juice. They include enzymes for carbohydrate and lipid digestion. That's pancreatic amylase for carbohydrate digestion, pancreatic lipase for lipid digestion, and also 3 very important protein digesting enzymes: trypsin, chymotrypsin, and carboxypeptidase. One key feature of these protein digesting enzymes is that they are secreted in their inactive forms. So they are not active in the pancreas until they get into the small intestine. Think about why we would want that to be. What would happen if you had protein digesting enzymes released in the pancreas? The pancreas would digest itself. So they're secreted as proenzymes, trypsinogen, chymotrypsinogen, and procarboxypeptidase, so that the pancreas doesn't digest itself. Yes, it is possible that a backup of these enzymes can occur from the duodenum into the pancreas, and that can cause damage to the pancreas, pancreatitis, or even worse, destruction of pancreatic cells. In addition to the pancreatic juices, alkaline fluid is secreted into the duodenum to neutralize the chyme from the stomach. Okay, that's the 3rd time we said that. It's important. Now the liver. The liver has so many functions, in addition to its role in bile production for digestion. It also is involved in bilirubin metabolism, fat and protein metabolism, carbohydrate metabolism, blood regulation, endocrine regulation, and detoxification. Because there's no other place for us to put all of these liver functions, I'm going to cover them here in this lecture. The liver is a large organ. It weighs about 3 pounds. It's huge. It's in the right upper quadrant, just inferior to the diaphragm. The majority of the liver is found in that right upper quadrant and is enclosed by the rib cage. It has an abundant blood supply. It also is regenerative, meaning that the cells can replace themselves. Here's the liver anatomy if we look anteriorly. The large right portion of the liver is its right lobe. The left, more pointed portion of the liver is the left lobe. Between those, we see the falciform ligament. Just tucked up under the liver is the gallbladder. Now, if we lift up the liver and look at its posterior surface, we'll see, now this image is flipped, right? Now we have the right lobe here and the left lobe here. We'll see the gallbladder tucked up underneath the liver there. We will also see that after the blood is processed in the liver, it will enter the inferior vena cava, which we're seeing tucked into the liver here. This is an important piece of anatomy because tumors of the liver, excess growth of the liver can actually impact the blood flow through the inferior vena cava. The blood supply coming into the liver enters, on the other hand, near the gallbladder. That's called the porta hepatis, and that's this group of blood vessels near the bile ducts. Porta means doorway, so this is the doorway into the liver. Into the liver here, near the bile duct, we have the hepatic portal vein, and the blood supply to the liver itself, the hepatic artery proper. Also, from this posterior view, we can see 2 smaller lobes of the liver. The quadrate lobe, which is this more square-shaped lobe, and the caudate lobe, which is more posteriorly towards the back of the abdominal cavity. The liver blood supply is unique, and it's important to understand. There's a large amount of blood flow into the liver from the digestive tract. So that nutrient-rich blood that has just absorbed all of those nutrients from the digestive tract are going to send blood into the liver. Oxygen-poor, nutrient-rich blood from the GI tract then passes through the liver before it enters the general circulation through the inferior vena cava. So let's look at this. We have 3 large veins that form into the hepatic portal vein entering the liver. Those are the splenic vein, the superior mesenteric vein, and the inferior mesenteric vein. These take blood supply from the digestive tract and the spleen and send it into the liver for processing. They enter the liver through the porta hepatis near the bile ducts. That blood gets processed in the liver and then will exit out of the hepatic veins to the inferior vena cava. The liver also needs its own blood supply. That's from the common hepatic artery, which branches from the abdominal aorta and the celiac trunk. The common hepatic artery then sends the hepatic artery proper, also next to the bile ducts, into the porta hepatis, and that provides a normal blood supply to the liver itself. That supplies the liver with oxygen-rich blood. Here's a summary of the liver blood flow. Pause for a second to take a look at this large source of digestive blood into the liver that's being processed. Then once it's within the liver, it's going to pass through the sinusoids of the liver so the hepatocytes can do all of their processing. After that, it will pass through the hepatic veins and leave through the inferior vena cava and return to the general circulation. Those hepatocytes in the liver are doing a lot. So I want to briefly show you the liver histology and the tiny lobules containing those hepatocytes. So the liver is divided into these microscopic lobules. Within these lobules, we have branches of bile ducts, hepatic arteries, and hepatic portal veins. They're going to bring the blood supply into the liver near the hepatocytes. The hepatocytes are the functional cells within the liver that are going to process that blood. We also have macrophages within the liver that help to detoxify the blood. These specialized macrophages are called Kupffer cells. And then there are hepatic stellate cells. These are responsive to liver damage and can lead to fibrosis and lipid accumulation if there's excessive damage or inflammation of the liver. Now let's talk about the functions of the liver, starting with blood regulation. We've mentioned through several other lectures the importance of albumin created by the liver. Albumin is one of the molecules synthesized by the liver. Here's a list of several other molecules that are synthesized by the liver. Coagulation factors that are important for blood clotting. Thrombopoietin, important for platelet formation. Cholesterol is synthesized in the liver, which is why we have medications that can target the liver to reduce cholesterol. Storage of vitamins, vitamin A, vitamin D, B12, ferritin, and even copper is stored in the liver. Also, release of hormones, IGF-1 for the growth hormone pathway, angiotensinogen for the RAS pathway, and then immune cells, B lymphocytes, immunoglobulins can all be regulated by the liver. The liver also has an important role in metabolism. Metabolism of fats, including cholesterol and bile production, and lipolysis or breakdown of fats. Metabolism of proteins, including protein synthesis, or proteolysis or breakdown of proteins. And then metabolism of carbohydrates, glycogenesis, or forming glycogen to store glucose, glycogenolysis, or breakdown of glycogen, and forming new glucose from amino acids and glycerol. That's gluconeogenesis. So the liver has a very important role in metabolism. Also, detoxification. The liver detoxifies drugs, metabolites, hormones, and toxins being processed here before they enter into the bloodstream. This is very important for applications like drug dosing, drug elimination, drug activation, and deactivation. And I'm sure you're going to hear about first-pass metabolism in your pharmacology course, because it's the cytochrome P450 system that metabolizes drugs and excretes them through the bile, and this can change the concentration of drugs within the system. And biotransformation, converting compounds for excretion in the bile and elimination in the GI tract. This reason here, by the way, is the reason I will never eat liver. I have people in my family who love to eat liver. I guess it's got all kinds of vitamins and all of that nice blood, but it also detoxifies and stores a lot of stuff. So no thank you. Okay, the liver is also important for bilirubin breakdown. the buildup of bilirubin is an important clinical sign. Let's zoom in on this image to look at this process. Red blood cells are broken down into heme and globin. The iron from the heme is recycled. And then we're left with porphyrins. Porphyrins are converted into unconjugated bilirubin. That unconjugated bilirubin then enters the liver through the bloodstream. The liver then conjugates the bilirubin. So when you see unconjugated bilirubin in your lab tests, you know that it hasn't been processed yet in the liver. When you see conjugated bilirubin, you know it's traveled through the liver. That conjugated bilirubin then is going to enter into the bile and be released along with the bile salts and other components of the bile. It passes through the bile ducts and into the duodenum to enter into the small intestine. So the conjugated bilirubin now enters into the small intestine. There, it's converted into stercobilinogen. Stercobilinogen has a brown color, and this is where my kids love my anatomy books because I tell them about why poop is brown. It's because of the red blood cell breakdown products, namely, ultimately, the stercobilinogen. That will then get released in the feces. We also have conjugated bilirubin that will be reabsorbed through the GI tract and can then enter to the kidney, and the kidney will convert it into urobilinogen. And this is the second reason my kids love my anatomy textbooks, because this is why pee is yellow. It's from the urobilinogen. But it's also, all kidding aside, it's also one of the reasons why the color of urine and the color of feces can help us understand something may have gone wrong in this pathway. If we don't have enough red blood cells to break down, that color might go away. If we have too much red blood cell breakdown, that color might increase. If we have some blockage in the bile ducts, and it can build up in the body, creating jaundice or hyperbilirubinemia. So many important pieces to understanding the bilirubin pathway. So this is hyperbilirubinemia, or too much bilirubin in the blood. Because bilirubin is this breakdown product of heme in the red blood cells, an increased blood cell breakdown or decreased elimination can lead to too much bilirubin in the blood. Bilirubin creates that yellow color to the urine and also the brown color to the feces. When bilirubin builds up, it can cause a yellowing color of the skin and the sclera of the eye. In light-complected patients, this can create a yellow-toned skin. In dark-complected patients, we need to look at the sclera or the white of the eyes to see that yellowing color or the evidence of jaundice. And then you want to figure out why. What's going on in this patient to cause this bilirubin buildup? So here are all the components of bile. Bile is this yellow-green alkaline fluid formed in the hepatocytes. It includes bile salts for fat digestion, bilirubin that we just talked about, a product of red blood cell breakdown. It also includes cholesterol, lecithin, and some alkaline fluids. When the bile is not actively being secreted through the bile ducts, it backs up through the cystic duct of the gallbladder and is stored in the gallbladder. So the gallbladder stores excess bile for later. Bile salts, which are involved in fat metabolism, are also reabsorbed through enterohepatic recycling. So the bile salts pass through the bile ducts, enter into the small intestine, and then some of that gets reabsorbed in the ileum, and they'll be returned to the liver through the hepatic portal circulation to be recycled. Remember that bile salts are necessary for emulsification. That's a physical separation of these large fat globules into small droplets suspended in the aqueous solution that is the chyme being mixed through the GI tract. This emulsification happens in the small intestine, and it's important for increasing the surface area for the pancreatic lipase to chemically break down the fat. So first, emulsification, and then enzymatic breakdown, both required for fat digestion. After that, those fats are then packaged into micelles to be absorbed through the intestine. And from the intestines, they're packaged again into chylomicrons to enter into the lacteals of the lymphatic system. Okay, last thing, the gallbladder. Bile is produced by the liver, but it's stored in the gallbladder. Then, from the gallbladder, there are bile ducts that join with the bile ducts of the liver. This is important anatomy because one of the peskiest things that the gallbladder does is to produce stones, and gallstones are very common in patients and extremely painful. So I want to zoom in on this anatomy here so you can see where these stones can possibly lodge within the bile ducts. So from the liver, we have the hepatic ducts. Remember, hepato refers to liver. So we have a left and a right hepatic duct, and those converge into the common hepatic duct. From the gallbladder, we have a cystic duct. Cystic refers to the sac of the gallbladder. So the bile from the gallbladder goes through the cystic duct. The cystic duct and the common hepatic duct combine together in the common bile duct. That common bile duct is then what enters into the hepatopancreatic ampulla and brings that bile into the duodenum, right next to the pancreatic juices from the pancreas. The hepatopancreatic sphincter is an important part of this anatomy. It's also called the sphincter of Oddi. This is where the common bile duct enters the lumen of the duodenum, combining with the main pancreatic duct. It empties bile from the liver and digestive enzymes and secretions from the pancreas. Before we end, I want to give you the gallbladder vocabulary, because when you're learning this in your medicine course, it goes really fast, and it's hard to get these different terms down. So chole refers to gallbladder or bile. Gall means greenish yellow. Doko refers to the duct. A lith refers to the stone. Remember that itis is inflammation. So cystitis is inflammation of a small pouch or inflammation of the gallbladder. And stasis means not moving. So let's think about some common combinations of these terms. There's one term called cholelithiasis. So let's break that down. What is a cholelithiasis? Cholelithiasis is a stone in the gallbladder. What about a cholecystitis? Cholecystitis is inflammation of the gallbladder. Could be because of a stone, but could be because of something else. What about a choledocholithiasis? This is a stone within the bile duct. You see the doco? The lith means stone, chole means gallbladder, doco means duct. So this is a stone within the bile duct. Okay, you can see how this terminology gets complicated. So put this in your back pocket so you recognize this vocabulary in your medicine courses in the future. Quick quiz. What is the location of abdominal pain with a cholecystitis? First of all, what's a cholecystitis? That's inflammation of the gallbladder. Where is that abdominal pain going to be? If you said right upper quadrant, you're correct. The liver and the gallbladder are located in the right upper quadrant. So a cholecystitis pain is often found very painful in the right upper quadrant. All right, that's it for this one. Let me know if you have any questions.